Thank you very much, Igor. And we have two more presentations. Oksana will speak about the morphology of the pancreas and then the final presentation of the current clinical trials. Good afternoon, dear colleagues. Thank you very much for the invitation to this very prestigious forum. So I will try to catch up and be shorter, sticking to time, because I will speak about the morphological assessment of pathological response. So I would like to answer all your questions before you ask them. My presentation will cover specifically morphology and pathology of this issue, on different schemes that were used and how it influenced overall survival, relapse-free survival, and I think the surgeons of our clinic can answer additional questions. So my topic is just pathomorphology. So the options of neoadjuvant treatment, I would like to say that they were already covered in the previous presentation, but let me say a few words on the options that we faced in our practice, which is arterial chemoembolization and systemic chemotherapy. And pathomorphological changes after the radiotherapy and combined chemoradiotherapy was not followed. The objective of neoadjuvant treatment, well, first and foremost, is to increase the R0 rate status, and as a result, improvement of relapse-free survival and also predictability of treatment, because we should look at the tumor response and finally, improvement of the overall survival. Let me remind you what is R0 status. R0 is when the tumor is more than away from 1 millimeter from the resection, and R1 less than 1 millimeter distance, and R2, this is macroscopic positive borderline. So let me remind all the audience and pathomorphologists that intimal surface of SMV is not the borderline of resection, and if this is arterial invasion, so usually these are not resectable forms of the tumor. What are the common pathological changes we see in our practice at earlier and later stages of different tumors? Not only pancreatic cancers, by the way. First and foremost, they can be split into early and late. It could be necrosis, fibrosis, a visual reduction of the tumor cell number, metaplasia, and the presence of giant ugly cells, and I will speak about that later on. So system of grading of adenocarcinoma in the periambulatory region. So we see the first grading was offered back in 1988 by the group of Ishikawa, so quite long ago. So Ishikawa and co-authors, they split residual tumors, so 1/3, 2/3, and more than 2/3. Looking at how many severely degenerative cancer cells they could observe. So later on, Evans and his group, and this is quite famous pathomorphological system, which is used for many localization, showed data on preoperative chemoradiation and pancreatic duodenectomy for adenocarcinoma of the pancreas. So they split a 4-tiered grading system for the extent of the residual tumor, and later on I will speak about it in detail. And finally, White and the team system. So this is similar, but reversed. So 0 is when 90% of the tumor was pathomorphologically changed. From 10 to 90 is grade 2, and grade 3 is when we do not see any reaction of the tumor, any response of the tumor, or just some destroyed cells after the neoadjuvant treatment. So very actively a system which is widely applied, similar to White. This is a system of American Pathology College, and this is College of American Pathologists, and this is protocol for the examination of specimen from the patients with carcinoma and endocrine pancreases. So this is 0, 1, 2, and 3, when there is no features of regression and no features of tumor destruction. This is Evans data. And I'm coming back to the system as I promised before. So with the increased grade you see less than 10, 10 to 50, 50 to 90, less than 10%, and Evans 4, where we do not see any tumor cells after neoadjuvant treatment. So this is a group of co-authors, and this is very good publication of 2012. They try to provide validation of Evans income using 223 serious cases of ductal adenocarcinomas, and then compared their data on overall survival and relapse-free survival using both grading systems. So from this article we can conclude that neoadjuvant treatment was combined, that was chemoradiotherapy provided to these patients. As you can appreciate from the survival curves, in fact, two systems, both CAP and Evans, quite comparable. In fact, they mainly coincide in their results, and in your practice you can use both, no limitations. That probably reflect the reality, but you can appreciate that relapse-free survival of grade 0 or Evans 4, 6 cases, which was 2.7%, when morphologists could see complete response. That means no cell, no tumor cell, complete response, CR. But definitely that was cytologically verified. And then follow-up 106 months. That means patient lived long and happy, and by the time of their treatment discontinuation they were still alive, and surprising but a fact. Also significant figures for grade 1 and Evans 3 correspondingly when relapse-free survival reached almost 40%, and the overall survival was even better, it was more than 50%. And these are top curves after the blue plateau, which is Evans grade 4. So it helps us to say that it is good response to neoadjuvant therapy, where the residual tumor meets CAP grade 0 or Evans 3 grade 3. So all that allowed investigators to split these groups into two significant groups, and to identify the threshold level, which is 5% or no tumor cell. 5% or no tumor cell, and then it matters for both overall and relapse-free survival. And this is group 1. And finally group 2, where the overall and relapse-free survival was just 20%. And I totally agree with this approach, and our morphological group as well, because it has particular sense. Later on I will comment on that. So I would like to say again that neoadjuvant therapy does not guarantee complete death of tumor cells beyond the resection borderline. So from the previous study, R0 was received even in group 2, 87%. And of course, in the first group, where it was almost complete response, R0 was 100%. But we do know that tumor is quite aggressive, and it is quite typical to have invasion on the perineural areas, and this is sliding down when the fraction parts of the cells are protruding much beyond in the bed of the distant, remote tumors. So there are several cells, always circulating tumor cells, and the mesenchymal target cells, they are still in the organism, in the body. To assess pathomorphosis, pathomorphological response, and to look at all the prognostic morphological criteria, definitely we have to follow dissection protocol, and we reported many times on that. But I would like to remind you that the VIP resection borderline is posterior level, labeled with a specific ink, and then the posterior surface, SMA surface, SMV. So these are parallel slices depending on the localization in the pancreatic head. This is how the dissection is performed perpendicularly to DPK, DPC, and then there is labeling. And this is how the complex is fixed, and then pathomorphological study is carried out on the all tumor tissues with very large capture of resection border with tissue samples to assess R0. In the dissection of organ complex, so if there is corpora and tail involved, then you have to perform dissection with the capture of remote spleen, if it is available, in order to understand the prevalence of the tumor into the spleen and neighboring tissues. I would like to remind you that before I'm showing you any pictures, demonstrating any pictures of micro pictures with pathological response, let me remind you the classical construction of the ductal adenocarcinoma, what sort of tumor it is and why it is so difficult to assess pathomorphological changes. Well, first of all assessment criteria designed, provided, and then translated to the pathomorphological changes assessment to the ductal pancreatic cancer, they were designed for the colorectal cancer, esophageal cancer, gastric cancer, but these cancers are cell-type tumors and stroma is minimal. But in the classical ductal adenocarcinoma, we do know that the special role belongs to stroma. It's always desmoplastic, colonized, rich with proteins, hyaluronic acid. That is why even at CT pictures, it also looks like fibrotic mass. And this is very difficult to assess pathomorphosis, both for radiotherapists and clinicians, also perineural invasion and vascular invasion shown here. Speaking about our clinic, we actively used hybrid technologies, arterial chemoembolization, preliminary arterial chemoembolization, and our lead is the advocate of all modern methods, and we see a number of PhD data. So you will see it later, so I will speak about pathomorphological response. In case of arterial chemoembolization, we split into the early injuries, so acute ischemic necrosis, you see very large areas. Well, microscopically, it was actual destruction, and by the way, it is never seen in the classical forms of the ductal adenocarcinoma. So usually inflammation is minimal there, not many mononuclears. But after chemoembolization, we can appreciate that tumor cells are flooded in the inflammatory infiltration. There is desmoplastic stroma destruction, which is important in the pancreatic cancer progression. We also saw a well-organized thrombus embolize when we studied the complex. And also there were some delayed changes after chemoembolization as well, and probably better seen. So this is removed native complex, and we did not clearly see the tumor, but in fact there was no tumor here. And only after our talk to the surgeon, with their help and comparison with CT pictures, we identify the area where we suspected that this is a residual tumor of pancreas. Definitely, primarily it was much bigger. So by Evans 2B, we considered it to be 2. And what was the appearance after this delayed pathomorphosis after chemoembolization? Here you can appreciate the reduction of cellularity, and the stroma itself also changed. In fact, it's not quite desmoplastic. So instead of ischemic danger and inflammatory flood, we still see restoration of stroma by the collagenization principle. Few cases of good response, which is Evans 3-1, when the tumor cells were single, and we could appreciate vascular invasion, and the arrow shows here, yes, singular tumor complexes.
После системной терапии у нас не такой большой случай, но тем не менее он имеется. В данном примере мы видим, что десмопластическая строма, в отличие от химиоэмболизации, она сохраняет свои свойства, и она совершенно не меняется, в отличие от предыдущей стромы. Но четко стрелками показаны места разрушения опухолевых клеток и, конечно, видимый патоморфоз. Клеточные опухолевые, которые наблюдаем, остаточная опухоль была 20%. Другие признаки проявления патоморфоза, которые мы могли наблюдать и опухоли других локализаций, это наличие уродливых клеток. Но как их расценить? Это компенсаторно-приспособительные реакции опухоли на воздействие лекарства, когда начинает происходить увеличение внутриклеточных структур, или все-таки это прогрессия опухоли? Это очень спорный вопрос. Когда есть небольшой, но ответ все-таки 70% остаточной опухоли, мы можем предположить, что такие уродливые наличия клеток – это все-таки наличие клеточного патоморфоза в опухоли. Вот очень хороший пример, когда 20% остаточной опухоли, в таком круге я его обвела, практически вся опухоль была представлена фиброзом и замещением жировой ткани, но при иммуногистохимическом исследовании данная опухоль продуцировала мезенхимальные маркеры, как P63 и цитокератины 5,6. Тоже что это? Это метапластические изменения, нахождение конечной дифференцировки, так как всего лишь 20% остаточной опухоли, когда опухоль уходит в более примитивные эпителии, или все-таки она изначально была сквамозным вариантом и хорошо ответила на химиотерапию. Это тоже очень дискутабельный вопрос. Морфолог не может до конца ответить, что же это, какие это проявления. Вот приблизительно такие вздутые светлые опухолевые клетки можно расценить как метапластическую реакцию. Мы ее так и оценили, потому что предварительные данные были, это инвазия в 12-перстную кишку, и мы видим на левом слайде всего лишь единичные измененные комплексы, а классический вариант инвазии в 12-перстную кишку на дальнем слайде от меня, это, как правило, буквально чистоколом врезается в мышечную оболочку протоковая аденокарцинома. И 5% остаточной опухоли по краю препарата стрелками тоже показано, и КАП-1 Эванс-3. Практически вся паренхима замещена фиброзом. Как же можем мы помочь сами себе оценить реакцию опухоли на неоадъювантную терапию? Наверное, помощь могла бы прийти из применения корбиоптирования опухоли предварительно, потому что цитологическое исследование, это мазок или, допустим, применяемый тот остаточный материал, который при эндосонографии получает тонкое игло, его недостаточно оценить клеточность. Корбиоптат дает полную картину, если он представлен вот такой низкодифференцированной протоковой аденокарциномой с низкой степенью стромального компонента выраженности. Но бывают и другие биоптаты. Вот такой же пример, где полностью фиброз, этот пациент не получал неадъювантную терапию, это стандартная верификация опухоли в нашей клинике, и мы видим, что в корбиоптате буквально цух опухолевых клеток, мы понимаем, что это протоковая.
Understand that this is a duct adenocarcinoma, but if the patient gets neoadjuvant chemotherapy, how can we assess the progress of the patient? Fibrosis, is it a response to neoadjuvant therapy, or the cellular pathomorphosis has taken place as a response to chemotherapy? I would like also to say a few words about, to make some conclusions and say that the developed criteria of pathomorphosis assessment are more objective when making preliminary core biopsy. Histological assessment of therapeutic pathomorphosis in the ductal adenocarcinoma of the pancreas is difficult, and neoadjuvant therapy does not guarantee the destruction of tumor cells outside the removed tumor. What are problems we are facing? First of all, the assessment of therapeutic pathomorphosis do not respond to all the questions of predicative therapy. Well, it is difficult for us to give a definite response to pathomorphologists. Probably new methods of tumor pathomorphosis assessment are necessary. We know that a lot of work was done on address genome by large institutes of the United States, and we're collaborating with these institutes, and we identified molecular types of the duct tumor. This is squamous, where TP63 is mutated, and the leading role is played by the genes that I show on the slide that were later differentiated, immunogenes, association with B T cells. And there are drugs that are receptors to the genes, and we know them. But molecular subtypes also have their history for ductal adenocarcinoma. The first papers appeared in 2011. They identified epithelial subtypes such as classical, exocrine, and quasi-squamous. Then in 2015 there were papers to this effect, in 2016 and 2019, and they also indicated that the stroma has a lot of importance in the advancement of the ductal adenocarcinoma. In Nature, in 2016, they studied 266 ductal adenocarcinomas and found subtypes. And I have already spoken about the subtypes from predecessors, immunogenic, adducts, and squamous. And recently we have read an article in the Gut. The trials showed the disadvantages of all the previous macrobiological tests, because the tissue samples that were provided for RNA sequencing, that was just a bulk of tissue. Of course, there was some requirements for cellularity, but RNA, they sequenced stromas and components, and the group of authors decided to divide, to sequence stroma and epithelial components separately, and to harmonize these subtypes. And what results did they get? They got a classical and basal like subtypes, and stromal subtypes, normal and others. And on the basis of this subtypes, we changed the schema, the adducts and immune like or immunogenic is closer to classic. ADAX was not confirmed, and the types were divided into epithelial squamous and quasi-squamous that give a very poor response to the first line of chemotherapy. And the classical or progenitor epithelial subtypes, they give a good response to first-line chemotherapy and a very good response to FOLFIRINOX. So where we have a good response, we may have a good overall survival. It seems to me in the future, we will molecularly assess pathomorphosis, because not a single paper is based on the histological assessment of PDAD. Because oncologists understood that the tumor may have a similar structure, but at different molecular disorders. So that's why we will focus on molecular disorders. And the failure of chemotherapy is associated with the fact that there is no point of applying chemotherapeutical drugs. The difficulty here is first epithelial parenchymal interaction, and when we find this point where they interact in this interaction, then the medical community will have good drugs for chemotherapy for further treatment of patients. And since I have been invited to the Pancreatic Club by my favorite surgeons, I would like to thank all these surgeons, to my chief Shabunin, Alexei Shabudin, Vladimir Bedin, Dmitry Grekov. This is really a group of brilliant surgeons working in our clinic and in our clinics. And of course, very many thanks to Professor Khatьков, Tsvirkun, Israelov, Lyadov, and others. Thank you, thank you, thank you very much. And I have forgotten to mention Professor Voskanyan on the slide. And I would like to remind you about the morphological group with whom we have been in contact for very many years. So since 2004, we have researched 840 resected organocomplex of ductal adenocarcinoma. Thank you very much for your attention. I hope I complied with the schedule.